Welcome back to Beyond the Stethoscope, the podcast for general practitioners. We know your time is, well, pretty stretched, so we aim to get straight to the useful stuff for navigating modern healthcare.
And especially for GPs and registrars, getting across chronic disease is just absolutely crucial, isn't it?
It really is. So, for this deep dive, we're tackling a big one: obesity. This is really tailored for you, our busy GPs, and particularly those of you prepping for fellowship exams.
Hmm.
We've gone deep into the obesity chapter in John Murtaugh's General Practice, trying to pull out the key knowledge you need.
Yeah, the goal today is to really unpack the essentials, clarify the pathophysiology behind those related conditions, cover the index cases properly.
Exactly. We want to boost your understanding, your confidence in managing what's become such a common issue.
It's a massive shift, historically speaking, from fighting infectious diseases primarily to now dealing with the fallout from chronic conditions like obesity. It's huge.
It really is. And the Aussie stats, they just underline it. Almost a third of adults obese, another third overweight. It's a major health burden.
Yeah,
And as Murtaugh points out, it's really a condition suited for long-term management in general practice.
absolutely. Because obesity isn't like, a quick flu. It's chronic, often relapsing. It needs that sustained, holistic care. And GPs, you're really in the best spot to provide that ongoing support, build that long relationship.
Totally agree. And to help us dissect all this, provide that expert guidance, we have our specialist with us today. Welcome.
Thanks. It's definitely a vital area for all of us in primary care to feel comfortable with.
Okay, so let's dive right in. Defining and measuring obesity. It's kind of amazing, isn't it, that Hippocrates, centuries ago, saw the link between being very fat and, well, dying younger.
It is striking. Shows some health truths that are pretty timeless. But now we have more refined tools than just observation. Body mass index, BMI, is still that fundamental screening tool.
Right, just a quick refresher for everyone. BMI is weight in kilos divided by height in meters squared.
Correct. And Murtaugh lays out the standard adult classifications.
Yeah.
Healthy is 18.5 to 25 kilometers Rs. That overweight is 25 up to 30.
Mm.
Class I obesity, 30 to 35. Class 2, 35 to 40. And Class 3, or severe obesity, that's 40 or more. Now, BMI over 40, it carries about a threefold mortality risk. Significant.
Wow, yeah, threefold. But the chapter also flags that BMI isn't, what, perfect. It has limitations we need to remember, right? Especially in general practice.
Oh, definitely. Key limitations.
Yeah.
The link between BMI and mortality isn't always straight up. It can be more J-shaped. And that curve, it shifts.
How so?
Well, things like ethnicity matter. Age, too. For people over 70, sometimes the lowest mortality risk is actually in the overweight range, not healthy.
Okay, interesting.
And the big one, BMI doesn't tell muscle from fat. Think about athletes, very muscular people. They might have a high BMI, but be perfectly healthy metabolically speaking.
Yeah, good point.
So BMI is a useful first screen, definitely. But you've got to interpret it in context, always.
That's a really practical point for everyday consults. So BMI is the start. What about waist circumference? Murtaugh highlights that too.
Yes, waist circumference. Super useful. It measures abdominal fat, that's central adiposity, and that's really strongly linked to the metabolic problems.
Okay, and how do we measure it accurately?
You measure midway between the bottom rib, the lateral margin, and the top of the hip bone, the iliac crest, at the end of a normal breath out.
Got it. And what are the cutoffs we need to know? The risk thresholds.
Okay, so for women, over 80 centimeters means increased risk, and over 88 centimeters is substantially increased, or high risk.
80 and 88 for women.
Yep. And for men, it's over 94 centimeters for increased risk, and over 102 centimeters for high risk.
94 and 102 for men.
Exactly. These numbers give a much better handle on that visceral fat, the metabolically active stuff, driving insulin resistance and heart disease risk.
The chapter mentions waist-hip ratio and skin fold thickness briefly. Are they practical for us day to day?
Waist-hip ratio greater than 1.0 in men, 0.9 in women, suggests higher CVD risk. It refines the central fat picture a bit more than BMI, sort of ample versus pear-shape idea.
Right.
Single skin fold, maybe over 25 millimeter, indicates more subcutaneous fat. But the 4 skin fold method, to estimate total body fat, it's generally too fiddly, needs special calipers and training. Not really practical for most GPs.
So it sounds like BMI first, then waist circumference for that abdominal picture. That's the most practical combo for us.
I'd say so, yeah.
Yeah.
Gets you most of the way there for risk assessment.
Now, here's a really important point Murtaugh makes.
Oh.
The higher death rate with obesity is mostly down to the complications, not obesity itself directly. Can you elaborate?
Yes, crucial distinction. Obesity alone maybe increases mortality by around 20%, according to the chapter.
Hmm.
But the really big hit to health and lifespan comes from that whole cascade of diseases obesity triggers or makes much worse.
Okay, which logically leads us to the core of the health conditions caused by obesity. Table 80.1 is pretty comprehensive. For exam candidates listening, understanding the why the pathophysiology is key.
Absolutely.
Let's start with cardiovascular, increased mortality, stroke, IHD. What's the mechanism linking obesity and heart risk?
Okay, so obesity triggers several things. It creates this chronic low-level inflammation throughout the body. That's one key factor.
Hmm.
It also causes endothelial dysfunction, basically damage to the lining of blood vessels. That's a really early step towards atherosclerosis, hardening of the arteries.
Right.
And then that extra fat tissue, especially the visceral fat, pumps out hormones and signaling molecules, adipokines. Many of these mess with vascular health, fuel inflammation, and contribute to insulin resistance, which we'll get to.
Okay, and hypertension. So common. Murtaugh says relative risk is over 3. How does obesity drive up blood pressure? What's the pathophysiology there?
It's multifactorial, really. One big mechanism is increased sympathetic nervous system activity. That pushes up heart rate, constricts blood vessels.
Okay.
Then, the renin-angiotensin-aldosterone system, RAAS, that often gets overactive in obesity.
Right.
Again, vasoconstriction plus sodium and water retention, so blood volume goes up.
Right.
And on top of that, often there's impaired production of nitric oxide. That's a molecule that normally helps relax blood vessels. So less relaxation, more constriction. Put it all together.
Sustained high blood pressure. Got it.
Exactly.
And last, under cardiovascular, varicose veins. This seems more sort of mechanical.
Yeah, largely. That extra body weight, especially with lots of standing or sitting, just puts more pressure on the leg veins.
Mm.
This pressure can damage the little valves inside the veins that stop blood flowing backwards. So you get venous insufficiency, leading to those varicose veins.
Makes sense. Okay, moving to metabolic conditions. Dyslipidemia, again, relative risk over 3. What lipid changes do we typically see and why?
The classic pattern is high triglycerides, high LDL, the bad cholesterol, and low HDL, the good cholesterol.
Right.
A big driver is the increased flow of free fatty acids pouring out of the excess fat tissue and hitting the liver.
Okay.
The liver then uses these fatty acids to make more VLDL, which gets broken down into LDL in the bloodstream. Plus, the insulin resistance that often comes with obesity messes with the enzymes controlling lipoprotein metabolism. All contributes to that atherogenic, risky lipid profile.
And then the big one we see constantly, type 2 diabetes,
Yeah.
also high relative risk. Murtaugh says obesity is behind most type 2 diabetes in European adults. Can you really break down the pathophysiology of this link for us? It's so fundamental.
Absolutely. It all hinges on insulin resistance. That excess body fat, particularly the visceral stuff, it releases those adipokines and inflammatory signals we mentioned.
Mm-hmm.
These molecules interfere with how insulin normally works in muscle and fat tissue. They make the tissues less responsive to insulin signal to take up glucose from the blood.
Right, so the glucose stays high.
Well, initially, the pancreas tries to compensate. It pumps out more insulin to overcome the resistance.
Okay.
But over time, those poor beta cells in the pancreas get exhausted. They can eventually fail, can't keep up with the demand. That's when blood glucose really rises and you get the diagnosis of type 2 diabetes.
I see.
And obesity is the major, major driver pushing people down that path.
That clarifies the progression really well. Next, hyperuricemia and gout. How does excess weight link to high uric acid and gout attacks?
Couple of reasons. Obesity is linked to increased production of uric acid,
Mm-hmm.
partly through increased purine metabolism.
Okay.
And at the same time, the kidneys might not excrete uric acid as effectively in obese individuals.
Mm-hmm.
So more production, less removal.
Huh.
Uric acid levels rise.
Leading to crystals in the joints.
Precisely. Increases the risk of those painful gout attacks.
Infertility is next affecting both men and women. How does obesity impact reproduction? Briefly.
In women, obesity can really disrupt the hormonal balance needed for regular ovulation.
Mm.
Makes cycles irregular, harder to conceive.
Mm.
In men, it can affect sperm count, quality, motility, and also erectile function. Again, hormonal changes, inflammation play a role in both.
And then PCOS, polycystic ovary syndrome,
Yeah.
another common one, often linked with obesity. What's the connection there?
It's complex, often a bit of a vicious cycle. Insulin resistance, super common in obesity, makes the hyperandrogenism, the high male hormone levels, seen in PCOS worse.
Right.
And then those higher androgens can actually contribute to more weight gain and metabolic issues.
Hmm.
So obesity can trigger or worsen PCOS, and PCOS can make weight management harder.
Okay, a real two-way street. Let's shift gears to the mechanical problems. First up, osteoarthritis, especially knees and hips. Seems like straightforward wear and tear.
Exactly. More weight means significantly more load on those weight-bearing joints,
Mm.
day in, day out.
Mm-hmm.
That increased mechanical stress just wears down the cartilage faster. Plus, that low-grade inflammation we talked about,
Mm-hmm.
that also contributes to cartilage breakdown.
Obstructive sleep apnea, OSA. Another big one, relative risk over 3. What's the mechanical issue causing the airway collapse in obesity?
It's mainly down to increased fatty tissue deposits around the neck and in the upper airway walls.
Okay.
So during sleep, when muscles relax naturally, this extra tissue can cause the pharynx, the back of the throat, to narrow or just completely collapse.
Blocking the airflow.
Yep. Leads to those repeated pauses in breathing, the apnoeas or shallow breaths, hypopneas. That's OSA.
Restrictive pulmonary disease is also listed. How does obesity restrict breathing?
The extra weight, especially around the chest wall and the abdomen, literally restricts how much the lungs can expand when you breathe in.
Right.
So total lung capacity goes down and it just takes more effort to breathe. Leads to that restrictive pattern on lung function tests.
Spinal dysfunction, back pain, again, seems mostly mechanical load.
Yeah, the extra weight changes body mechanics, puts more strain on the muscles, ligaments, discs in the spine, alters posture. It all contributes to chronic back pain, spinal issues.
And finally, mechanical urinary incontinence. What's the link to bladder control?
It's thought that the increased intra-abdominal pressure from the excess abdominal fat puts extra stress on the bladder and the pelvic floor muscles.
Mm-hmm.
Over time, this can weaken those supporting muscles, leading to stress, incontinence, leaking urine when you cough, sneeze, exercise, anything that bumps up that abdominal pressure.
Okay, that covers the mechanicals.
Yeah.
Now, the other category, hiatus hernia and URD reflux. What's the link?
Again, it's that increased abdominal pressure. It can push the top part of the stomach up through the diaphragm opening where the esophagus comes through. That's the hiatus hernia.
Right.
And that hernia can weaken the valve between the stomach and esophagus, making it easier for stomach acid to reflux back up, causing GERD symptoms.
Gallbladder disease, another one with relative risk over 3. Pathophysiology. Why the link?
Obesity often leads to the liver producing bile that's supersaturated with cholesterol.
Mm-hmm.
Too much cholesterol in the bile increases the risk of cholesterol gallstones forming. Also, sometimes gallbladder emptying can be a bit sluggish in obesity, which further encourages stone formation and raises the risk of cholecystitis, inflammation of the gallbladder.
Fatty liver, NSH, non-alcoholic steatohepatitis. Huge issue now. How does obesity cause fat buildup in the liver?
Insulin resistance is central here again. When cells resist insulin, the body makes more insulin. High insulin levels promote fat storage, including in the liver.
Mm-hmm.
Plus, you've got that increased flood of free fatty acids coming from the fat tissue straight to the liver. It just overwhelms the liver's capacity to handle it, leading to fat accumulation, inflammation, and potentially ination.
The chapter mentions increased cancer risk, too. Doesn't specify which ones here, but it's a known link. What are the general ideas behind why obesity raises cancer risk?
It's thought to be a mix of things. That chronic low-grade inflammation we keep mentioning is a big factor. Also, elevated levels of certain hormones, like insulin, insulin-like growth factors, and estrogens from fat tissue, and changes in cell metabolism. All these things can create an environment where cancer cells are more likely to grow and thrive.
Kidney disease next, mentioning checking for microalbuminuria. How does obesity damage kidneys?
Often, in obesity, the kidneys initially work harder, filtering blood at a higher rate. It's called glomerular hyperfiltration.
Okay.
While that sounds good, over time, that extra workload can damage the delicate filters, the glomeruli, leads eventually towards chronic kidney disease. Microalbuminuria, tiny bits of protein in the urine, is an early warning sign of that damage.
Excessive daytime sleepiness, linked to OSA mainly.
Yeah, strongly linked to OSA, which is so common in obesity.
Wow.
But also, the metabolic disturbances themselves can affect energy levels and alertness.
Erectile dysfunction, male subfertility mentioned again, related to the hormonal and vascular issues we touched on.
Exactly. Hormonal imbalances, impaired blood flow due to vascular issues.
And finally, psychological problems, depression, anxiety. This is complex, isn't it? Both social and biological factors.
Absolutely. Living with obesity can be really tough emotionally. There's social stigma, body image issues, the frustration of managing it. That takes a toll.
Yeah.
And then there's growing evidence that the chronic inflammation and metabolic changes in obesity might actually directly affect brain chemistry and mood regulation increasing vulnerability to depression and anxiety. It's
Yeah.
bidirectional.
What a list. Going through the why for each really hits home how widespread the effects of obesity are. Okay, let's shift focus. Understanding the causes of obesity. Murtaugh splits this into primary and secondary. Let's unpack the primary causes first.
Right. The NHMRC guidelines are key here. They stress diet and physical activity are central, obviously.
Mm-hmm.
But critically, these are influenced by a whole web of other factors. Social, environmental, behavioral, genetic, physiological. It's
Feels
plus.
not just individual willpower.
Not at all. Hormones are huge regulators. Ghrelin, the hunger hormone, drives appetite. Leptin, from fat cells, signals fullness. Insulin, thyroid hormones, they all play roles in energy balance.
And the chapter mentions the body sort of resetting its weight thermostat higher.
Yeah, the set point theory. With chronic energy surplus, the body's regulatory systems can adapt to defend a higher weight, making sustained weight loss harder. It's a physiological challenge.
And that tendency is influenced by.
Genetics play a part, for
Hmm.
sure. Epigenetics, too, things happening even in utero that affect gene expression later. Early life counts, antenatal care quality, breastfeeding support, these things can have long-term echoes.
Then there's the obesogenic environment, our surroundings basically pushing us towards weight gain. The U.S. fast food density example really illustrates that.
Absolutely, Professor Gary Ayer's analogy, the canary in a mine shaft, is spot on.
How
He argues that tackling population obesity means looking upstream at the environment itself. Things like food marketing, availability, and cost of healthy versus unhealthy food, sports programs, how our cities are designed for walking or driving.
All right, the bigger picture stuff.
Yeah. Though, as Murtaugh notes, how much individual GPs can or want to engage in that broader advocacy varies, obviously.
Makes sense. Systemic problems need systemic solutions. Okay, now, secondary causes. Medical conditions or treatments causing weight gain. Table 67.1 is referenced, though we don't have it here.
Exactly. Always have to consider secondary causes when someone presents with weight gain. Broadly, think modifiable and non-modifiable.
Modifiable being mainly.
Often iatrogenic, medication-related. Steroids are a classic. So antipsychotics, some diabetes meds like certain sulfonylureas or insulin itself.
Mm-hmm.
If it's clinically safe and possible, you might look at reducing the dose, stopping or switching to an alternative drug with less weight gain potential. Always carefully collaborating with the patient and maybe specialists.
And non-modifiable causes.
Things like some congenital syndromes or certain chronic illnesses where weight gain is part of the disease process itself. Here, the focus isn't on curing the cause of weight gain, but managing the obesity and its consequences to improve health and function.
So diagnosis is key, especially if the weight gain is recent or rapid.
Crucial. Good history, thorough exam, relevant tests, rule out things like hypothyroidism, the classic endocrine cause, and importantly, differentiate true fat gain from fluid retention, like in heart failure or nephrotic syndrome, which can look like rapid weight gain but isn't adiposity.
Right, careful assessment is vital. Okay, let's get practical. Managing obesity in the clinic. Raising the issue that first conversation can be tricky. Murtaugh suggests looking for openings.
Yeah, it's about timing and opportunity. Maybe the patient brings it up first, or they present with something related, high LFTs, needing BP med repeats. Health checks are a natural time,
Mm-hmm.
or sometimes just opportunistically.
Mm-hmm.
The key is sensitivity.
Really?
Pick your moment. Use non-judgmental language. Really listen. It's often a very loaded topic for people.
Absolutely. And that weight stigma issue the chapter raises is so important. In society, even in healthcare sometimes.
It really is. That stigma, that bias, can make people feel judged, blamed. It can lead to them avoiding health care, delaying seeking help for related problems. It's a real barrier.
We need to be mindful of that bias in ourselves, too.
Definitely. And another point flagged is screening for eating disorders, bulimia, binge eating. If suspected, unless you have specific expertise, referral to specialists is the way to go.
Right. So once the conversation is started, the focus shifts to behavior change. Murtaugh says this is the cornerstone, even if meds or surgery are involved later.
Absolutely fundamental. You can't bypass behavior change. Motivational interviewing techniques are really useful here
Why am I specifically?
because it helps shift the motivation from external, like the doctor telling them to lose weight, to internal, finding their own reasons for change. It explores their ambivalence, builds their confidence. It's collaborative, not directive.
Okay. And the chapter mentions that eating and exercise habits are learned so they can be unlearned or modified. What strategies can we discuss?
Things like stimulus control, changing the environment to avoid triggers for unhealthy eating, addressing negative thoughts about food or body image,
Hmm.
Maybe referral to a psychologist for CBT could help there.
Mm-hmm.
Identifying barriers, what actually stops them from eating well or exercising, and then problem solving together to find realistic solutions.
The stages of change model is mentioned briefly. How does knowing the patient's stage help us tailor the consult?
It's about meeting the patient where they are.
Yeah.
Someone in pre-contemplation isn't ready for an action plan. They need awareness raised, maybe gentle information.
Right.
Someone in preparation is ready to plan, set goals, figure out steps. Action is doing it. And maintenance, that's about sustaining the changes, avoiding relapse. The rubber band analogy is good. There's always a pullback to old habits. Maintenance needs ongoing support.
Okay, let's dig into the specifics now. Diet. Murtaugh emphasizes a healthy pattern based on whole foods.
Yes. More unprocessed stuff. Vegetables, fruits, whole grains, legumes, lean protein. Less of the typical Western diet culprits, sugar, saturated trans fats, salt, alcohol. Basically follow the NHMRC guidelines referenced in Chapter 5.
And when patients ask about specific diets, keto, paleo, whatever's trending,
Key things to assess are, is it nutritionally sound? Is it safe? And crucially, is it sustainable long-term? Lots of diets give quick initial loss, but if you can't stick to it, it's not helpful.
which diets get a specific nod for evidence?
Mediterranean and DHH diets have good evidence for health benefits and sustainability. Others like intermittent fasting, some low-carb approaches, commercial programs they can work for some, usually by cutting overall calories, but assess them carefully.
The 5S model is suggested for structuring dietary advice. Can you quickly recap those A's?
Sure, ask about their diet, knowledge, readiness. Assess weight, waste, health issues, intake.
Yeah.
Advise based on guidelines tailored to them. Assist with goal setting, planning, resources. And arrange follow-up. It's a useful framework.
And collaboration with dietitians, APDs, is strongly recommended.
Absolutely. GPs should build links with local APDs. They have the time and expertise for detailed, personalized dietary plans. Dietitians Australia website is the place to find them. It's a really valuable referral.
During reviews, Murtaugh advises against just focusing on the scales.
Yeah, don't make it all about the weight number. Food and exercise diaries give a richer picture of effort and patterns. Ask about energy, mood, sleep. Look at BP, HbA1c improvements. These are all wins, even if weight loss is slow. And diaries can sometimes flag disordered eating patterns too.
The chapter gives some calorie kilojoule examples and then discusses the direct trial. That UK study showed impressive results with intensive diet and primary care.
It really did. Landmark stuff. They used a total diet replacement phase, low-calorie shakes for 3 months, then structured food reintroduction and ongoing support.
And the outcomes.
Pretty stunning. At 12 months, nearly 25% of the intervention group lost 15 kilograms or more. 0 in the control group. Average loss was 10 kilogram versus 1 kilogram. And the big one, 46% of those with type 2 diabetes achieved remission off meds compared to just 4% in the control.
Wow. Remission.
Yeah. And much of the benefit held up at 2 years with ongoing GP support. It proved that significant results are possible in a general practice setting with intensive dietary focus. Really encouraging.
Incredibly so. Shows what's possible. Okay, let's pivot to exercise. Murtaugh stresses its huge benefits, often overlooked.
Totally. The HAM-D guidelines are full of evidence for exercise benefits across countless conditions, way beyond just weight. Important to manage expectations, though. Exercise alone usually doesn't cause massive weight loss unless you're doing heaps, like maybe 90,000 steps a week equivalent.
But health improves even without big weight loss.
Definitely. Reassure patients about that. Better BP, better mood, better sugar control. These happen with increased activity, even if the scales don't budge much initially.
So for weight loss, it's exercise plus diet. What's the exercise prescription?
Combine it with calorie reduction for weight loss. Aim for at least 150 minutes a week of moderate activity, something sustainable. That's about 70,000 steps, burns maybe 2,500 kilocalories in an 80-kilogram person.
And for keeping weight off after losing it, maintenance.
That often needs more exercise. Maybe 60, 80 minutes a day of moderate activity, pushing over 100,000 steps a week, alongside sticking to a healthy, probably lower-calorie diet. Maintenance is hard work.
What makes exercise stick? Become a habit.
Key factors: enjoyment, gotta like it, or find a way to. Affordability, fits their schedule, part of a routine. Doing it with friends or groups helps massively. GPs should know local free options, parkrun, counsel programs, walking groups, get people connected.
Right. Okay, let's talk medications. Murtaugh seems pretty cautious here.
Very cautious, acknowledges the commercial drivers, but states clearly, there's currently no medication that's safe, well-tolerated, and gives clinically significant, sustained weight loss with proven reduction in morbidity mortality. Lifestyle first, always.
So avoid recommending unproven stuff.
Absolutely. No unproven meds, supplements, over-the-counter things, weird devices. Stick to evidence.
What about the ones with some evidence? Or the stat?
Orlistat reduces fat absorption, only one evaluated long-term for safety. Main issue is GI side effects wind, oily spotting, especially with fatty meals. Dose is 120 milligrams 3 times a day with fatty meals. Murtaugh says only continue past 12 weeks if they've lost at least 5 kilograms.
Okay. And phentermine?
Available here, but only for short-term use, max 3 months. It's an appetite suppressant. Side effects can include high BP, fast heart rate, insomnia. Long-term safety just isn't tested. Use with caution, if at all.
Any others mentioned? Meds for other things with weight loss side effects?
Yeah, briefly mentions metformin, fluoxetine, topiramate can sometimes cause modest weight loss, and the newer diabetes drugs, SGLT2 inhibitors, GLP-1 agonists.
Right, the GLP-1s get a lot of attention now.
They do. They offer modest weight loss, maybe 2.5 kilograms a year for SGLT2s, maybe 4-6 kilograms for higher dose liraglutide, a GLP-1. But importantly, they're not PBS subsidized for weight loss alone. They have proven heart and kidney benefits when used for diabetes, which is great, but they aren't primarily weight loss drugs in the current funding landscape here.
Got it. Finally, bariatric surgery. What's the aim and what are the options?
The aim is basically to reduce intake, either by making the stomach smaller, restriction, or reducing nutrient absorption in the small bowel, or both. Options mentioned are adjustable gastric banding, sleeve gastrectomy, and Roux-en-Y gastric bypass.
Comes with risks, though.
Oh yes, major surgery. Mentioned about a 5% risk of complications needing hospitalization and roughly 1 in 500 mortality risk. Plus, need long-term monitoring for nutrient deficiencies like iron and B12.
But the outcomes can be significant. Weight loss, health improvements.
Definitely. Can get substantial initial weight loss, 20-30% often in those with BMI over 35. Good long-term maintenance, around 20% loss. Research shows improved physical quality of life, mobility, big improvements in metabolic risk factors. Diabetes often goes into remission, lower BP, lipids, reduced CVD events and deaths.
Any caveats?
Interestingly, Murtaugh notes psychological well-being doesn't always improve significantly post-surgery. It's not a magic bullet for everything.
And cost?
Significant upfront cost, yes. Needs ongoing follow-up, too. But, the chapter points out, it can compare favorably long-term against the cost of managing complications, especially expensive diabetes meds like insulin or the newer agents.
Who should we consider referring? What are the criteria?
General criteria mentioned are BMI over 40 or BMI over 35 if they have comorbidities like type 2 diabetes or severe OSA that are likely to get better with significant weight loss.
Okay. We have covered a huge amount today, really unpacking that Murtaugh's chapter. If we were to boil it down, what are the absolute key takeaways for our listeners, especially those studying for exams?
Okay, number 1, obesity is complex. Genetics, environment, behavior, physiology is all intertwined. 2, assess properly BMI plus waist circumference, but know their limits. 3, grasp the pathophysiology. Understand why obesity causes those index conditions like diabetes, heart disease, OSA. 4, always think primary and secondary causes. Rule out underlying conditions. 5, management is multifaceted, but lifestyle, diet, and exercise is always the foundation. Know the options, from behavior change support right through to medication and surgery indications.
And that message, reinforced by the direct trial that GPs can make a massive difference, that's really empowering, isn't it?
Absolutely. With the right approach, knowledge, and support systems like dietitians, you can genuinely change lives in general practice.
So for everyone listening, maybe just reflect on one thing from today's deep dive you could bring into your practice. Maybe focusing more on waist circumference or exploring motivational interviewing or building that link with a local dietitian.
Small changes can add up.
It's about that ongoing learning, that patient-centered, evidence-based approach to tackling this really significant health challenge.
And remember those resources, Dietitians Australia website, the Handy and I guidelines, they're there to help.
Thank you so much for sharing all your expertise today. It's been incredibly valuable.
My pleasure. It's an important topic.
And thank you all for tuning in to Beyond the Stethoscope, the podcast for general practitioners. Join us next time as we dive deep into another key area for your practice.
Until then, take care and keep up the amazing work you all do.